Guys, well, this is your introduction to clinical pharmacology, chapter 1. This is the general principles of pharm. So, to kind of a brief overview. So, let's talk about it. What is pharmacology? It's the study of drugs, their actions on living organisms, right? And we need to be safe when we're administering medication. And we as nurses, we're the last safety net between the patient and the grave. So we're the ones administering the meds. We have to be sure that the order is right because people make mistakes. Okay. All right. So when we talk about drug names and classifications or categories, with drug names, there's a chemical name, which is the generic, and then there's a trade name, the brand name. Always use the generic to avoid confusion. The board will give you questions with the generic name. So it's not Coumadin, it's warfarin. Okay. So you want to make sure that you stick with that. Okay. When we give a person a medication, meds act in different ways, right? How quickly do they get dissolved? How quickly do they get absorbed, distributed, metabolized, excreted? All of these things have to happen in order for the drug to do what it's supposed to do in the body. Okay. Let's talk about different forms of drugs. So there are liquid or parenteral drugs. They're already dissolved because they're liquid, so they get absorbed pretty quickly. There are solid forms of drugs. This can be tablets, capsules. You swallow them, they disintegrate into little particles, and they dissolve into body fluids in your digestive tract. Enteric-coated tablets, they disintegrate after they reach an alkaline environment, which is your small intestine. So in other words, most of these tablets or capsules break down in your stomach with the hydrochloric acid. Enteric-coated tablets do not. They go through the stomach to the small intestine and slowly break down. Okay. Never break, cut, or crush an enteric-coated tablet. Okay. So absorption. Absorption is how quickly the particles of the drug in the GI tract move into your body fluids. And factors that influence the rate of absorption. How did we give you the drug? What was the route? Was it PO? Because PO is slower. IV's quickest. Was it sub-Q or IM? They're kind of in the middle. Okay. And then we've got metabolism and excretion. Excretion means the elimination of whatever drug is left from the body. If you have a patient with kidney or liver disease, they usually will require a dosage reduction and careful monitoring of either their kidney, renal, or liver hepatic function. Remember, those two organs, your kidneys and your liver, are responsible for filtering your blood of toxins, so they're primarily responsible for the excretion of medications. Older folks, their kidneys and liver don't work as quick as with others, not me, other old people. So they require careful monitoring and lower dosages sometimes. Okay. And like I said, the kidneys and liver are the primary organs for the excretion of these medications, all of them. Onset of action means how long does it take between the time I give you the drug, the administration of it, and the therapeutic effect, right? And then the duration of action is how long does the drug take to produce its therapeutic effect, and how long does the therapeutic effect last? Okay. I took ibuprofen because I had a headache. How long did it take for my headache to go away? And how long did it keep my headache away? Right? Make sense? Drug reactions. You've got to know these. People can have an allergic drug reaction. So what is an allergy? An allergy is a hypersensitivity response to a normally benign substance. When you expose yourself to something that produces an allergic response, the first exposure is usually pretty mild. Itchiness, which is pruritus, urticaria, which is hives. But subsequent or repeated exposure can cause anaphylaxis, and that can kill you. There's something called drug idiosyncrasy. That means that the drug did the opposite of what it was supposed to do. I give you a chill pill like alprazolam, and you're bouncing off the walls. Idiosyncratic reaction. Drug tolerance over time and with regular use, right? Your body will get used to a drug and you're going to need more and more and more, higher doses, or maybe even a different drug altogether to get the same therapeutic effect. Okay. And that's with most drugs. Cumulative drug effect. If a patient receives a next dose of a med, but the previous dose hasn't had time to excrete completely, they can go toxic. And then what is toxicity? What's a toxic reaction? It's a buildup of the drug in the patient's blood that causes some kind of a harmful or deadly reaction. Okay. And let's see. So hypersensitivity response, allergic reaction. Your body views an antigen or views the drug as an antigen or something dangerous. And so your body reacts. What are signs and symptoms? Itching all of a sudden, right? Rashes, hives, wheezing, cyanosis. They start to get a little blue. Sudden loss of consciousness. And they can get swelling of the eyes, lips, or tongue, which is called angioedema. And that can lead to anaphylactic shock, which can kill you. Okay, and we'll get into that when we talk about shock later on down the line. So, drug idiosyncrasy. So, usual, unusual, abnormal, sometimes an extreme opposite reaction to a drug, different than what we expected. What causes it? Idiopathic, which means, I don't know, drug tolerance. You need more and more of a drug to get the same desired effect. People that are opioid dependent will typically just worry about not getting dope sick. They're not even sometimes worried about getting high. They need some of the drugs so that they don't get sick because they build up such a tolerance. Cumulative, oops, I skipped that, my bad. Cumulative drug effect. You see this with people with kidney disease or liver disease and with older folks. So the body can't get rid of the previous dose, and now we're giving you your next dose. So in these cases, the dose should be lowered to prevent a toxic reaction. Anatoxic reaction is where the levels of the drug in the blood have exceeded what the therapeutic level should be. Okay. Some drugs have antidotes, which we can give, right? So if somebody's toxic, say with a benzodiazepine, we can give them flumazenil, and that can reverse the toxic effect. But not all drugs have antidotes. Okay. Then additive drug reaction. That means that the combined effect of two different drugs is equal to the sum of each drug given alone. So in other words, an Advil and a Tylenol, right? Each of them is still giving its own effect. But a synergistic drug reaction is when drugs interact with each other and produce a total sum greater than the sum of them separately. 1 + 1 = 5. I give you a Percocet and I give you a Xanax. So oxycodone, APAP with alprazolam. Two different drugs. One's a benzo, one's an opioid. But when you give them together, they do this real groovy thing where you're like, whoa. So 1 + 1 = 5. And then antagonistic drug reactions. An antagonist drug is a drug that blocks the action or the effect of another drug. Naloxone blocks the effect of opioids. Okay, that's an antagonist. Drug-food interactions. Different drugs can be taken on an empty stomach. Some need to be taken on a full stomach. Lots of different drugs have lots of different instructions, right? You need to make sure that you know what you're giving and when it should be given. Many drugs don't like grapefruit juice. Statins for cholesterol don't like grapefruit juice. Warfarin, anticoagulant, doesn't like grapefruit juice. The list goes on and on. So you have to make sure that you know about drug-food interactions. Always look the drug up in your nursing drug book before you administer it. Question, is the following statement true or false? Age is a factor that influences drug response. If you said true, not Miss Mary, though, you would be right. Age, weight, gender, diseases, route of administration, these are all factors that influence how a person will respond to a drug, right? And you never know till you give it to them. So these are the factors that influence drug response. Like I said, age, weight, gender, different diseases, and the route of administration, because IV, the quickest. PO, pretty much the slowest. Okay? And there's your introductory to clinical pharmacology. I'm dropping the mic. Boom! We're done. We're moving on. See you at the next video. Peace and out.